Great. So welcome to this webinar that's organized by the South African Academy of Family Physicians with Dr. Nicholas Crisp, who I'll introduce just now, but I think you can see him on the screen. And just a brief introduction from me. So welcome to all of you that have joined us. We think there's quite a mixed group of family physicians in public and private sector, general practitioners, primary care doctors. So welcome to all of you. I guess I should say, while I have the chance, that if you're not a member of the Academy and you'd like to join, then please have a look at the website and think about joining, or speak to your Yolita, who you got an email from. So the purpose of today, so this journey started last year. Obviously, when the NHI bill went before Parliament, which I think was sort of the middle of last year. And following that, we did a survey of the members of the Academy. And one of the outcomes of that survey was that people were saying they're not really sure of what NHI is all about in detail and what the implications are for people in primary care and district health services. And people wanted more engagement. They wanted to have a bit of more input into how things were being planned and unfolded. And as a result of that, we then decided to publish a series of 4 articles in the South African Family Practice Journal with Nicholas Crisp as a sort of consultant. So we just published the 4th article in that series. And they essentially are forming the sort of the framework or the template for what is now 2 webinars where you can actually get to engage and talk to Nicholas Crisp about these issues. So the 4 articles, the first one was on the big picture. The second one, I think, was on accreditation of primary care facilities. The third one was on patient registration and practice populations. And the last one mostly was on remuneration of primary care providers. So today, we're taking the 2 topics of the big picture for NHI and patient registration. And then at the second webinar, which is on the 19th next week at 4 o'clock, to look at accreditation and remuneration. Now, I know we probably won't stick religiously to these topics, but that was the plan. So let me just introduce Dr. Crisp. I found his CV online, so I hope this is up to date. So he is a medical doctor, and he's a specialist in public health. He had a long career in health management. He actually was, I think, the first head of the health department in Limpopo in the 1990s, from 1994 to 99. And after that, he's consulted many countries in the African region on management issues related to district health services. And he's been involved, I think, in the setting up of the National Health Laboratory Service in South Africa, the Forensic Pathology Services, and more recently, the South African Health Products Regulatory Authority. So he certainly knows his systems and his service design. And now he's taking on national health insurance as a sort of consultant to the National Department of Health. So, so the process that we're going to follow is that Nicholas is going to give us a sort of 15-20 minute input on national health insurance. And then after that, it's over to you to ask questions and to interact with him. I think in this particular form of Zoom, you have to use the question and answer tool, which you should find at the bottom of your screen, and you can type your questions in there, and then I will select and feed them for responses from Nicholas Crisp. And we'll go up until 5 o'clock. And then we'll stop and we can continue next week with further discussion. So thank you. Nicholas, over to you for your presentation.
Okay, thanks very much, Bob. And thank you to all of those who have attended this afternoon. 1 hour is a very short space of time. And what I'm going to do is I'm going to go through a presentation as quickly as I can. And it's not always that easy to follow. So if you make notes, and even if you ask questions off cue or off point, it's fine. I really don't mind. It's important to me that more and more people understand what NHI is about and where you may fit in. But you also need to know that this is a reform process. It will take time, and we don't have all the answers for the finer details. We do know where we're going, but we don't have all the answers for all the details. So let's jump into it. We're going to deal, as you heard, with the big picture and registration of patients, and then we'll come back next week and talk about accreditation and remuneration. So let's start with the big picture. And what I want to do is talk about what is NHI, who's covered by NHI, can we afford NHI, how will the NHI be governed, what then is the role of the national, provincial, and district structures, and what's the role of the medical aid schemes. So let's start with a point of departure. Our current health system is precarious, to say the least, and we saw that during COVID. We really struggled with parts of our health system, and we were not really able in the beginning of the COVID to respond very well to the epidemic. Thank heavens we had time to get ready. Our funding model is very inefficient, both the public and the private sector, and they perpetuate and multiply inequality and inequity rather than solve the problems. And unfortunately, although we spend a lot of money on healthcare, our system, and I'm talking about public and private, the entire health system, produces pretty poor health status results. So it's not really a sustainable system, and we need to fix it. So what are we trying to do with the reforms that are on the table? Primarily, we must reduce inequity. We can't have a situation where we have a lot of people with a few people with a lot of access to healthcare and a lot of people with little access to healthcare. We want to provide access to healthcare based on our need, not on our ability to pay. I'll talk a little bit more about that, and you're welcome to ask questions. We want to make sure that the health system addresses the national priorities, and they're clear what they are. And especially now with non-communicable diseases, particularly diabetes and hypertension being such a massive challenge, they are obviously national priorities that we must address in our health system. We need to reduce administrative inefficiencies. There are many, both public and private sector. And if you read the Health Market Inquiry Report, or what's known as the HMI, you will see there that at least 15% of everything that is spent in the private sector is spent on administrative overhead. And I'm not talking about running hospitals and your practices. I'm talking about the administrative overhead of the financing system. And the last thing we want to do is remove the burden of payment at point of care. So we don't want a situation where someone lands up either in a private hospital or in a public hospital, or you have to care for these patients and they cannot pay at that point. We want everybody to be prepaid using taxes, and that when you need healthcare and you end up at any point in the health system, you don't have to panic about how it's going to be paid for. So what is national health insurance then? The first thing to say is it is a health financing system. If you look up national health insurance generically, not South Africa's one on Google, or look it up in the health literature, you will see it's a health financing system, and it is designed to pool our funds and provide access to quality, affordable personal health services. So we're not talking about the environmental health services and the other non-personal health services. The NHI is targeting personal health services. And the reason it's a national service and it's insurance rather than something else is because it is based on our needs and it's irrespective of our socioeconomic status. So the primary aims of NHI is to achieve universal health coverage. And many people say to us, well, you've already got universal health coverage. Well, we don't. We have inequitable universal health coverage. What we want is to cover more people with more or a greater range of services, which are called benefits in the bill. We want that to cost less and in fact nothing at point of care, as I've said, and we want to improve quality throughout. So how do you design a system that does that, and why do we need national health insurance? Well, healthcare is the departure point for us, and our constitution is healthcare is a human right. It's pretty internationally acceptable, and it should not be dependent on our financial status. So if I don't have enough money and I've got a hospital plan that excludes something, I shouldn't have to sit at home and wait until I've saved up enough money to go for my healthcare. I should be able to get it when I need it. Our present system, as I've said, is fragmented. The public sector is ill-equipped and understaffed, and it's a wonder that our staff who stay there are able to do the work that they are able to do, serving 85% of the population. The private sector is fragmented, it's overserviced, and we now have measures of how overserviced it is. It's certainly over-specialized, it's very expensive, and it serves only about 15%. You could argue 18, 19%, but there's an overlap between the public and the private sector where there's a segment of the population who uses both interchangeably, depending on how much money they've got on the day. The problem is that this system of ours costs us 8.5% of our GDP, which is about 500 billion per annum. And it is not possible for us to just address one half. I know people say, why don't you just fix the public health system? You can't, because the resources are so intimately shared and there are so many resources in the system that what we need is a facelift and lots of systemic changes, never mind the local changes. So what are we trying to do? We want to pool all of our resources into one fund instead of 74 private funds and 9 provinces. And we want to purchase those funds or benefits from one single point and as an automated system as possible on behalf of the whole nation. Whether you have paid a lot of tax or a little bit of tax, you've all paid something, and we want to purchase it from there. And the fund wants to contract directly with service providers, not via third parties, not through agents, and not through provincial administrations, directly from service providers. So we're going to get to the user question in a moment, but the users need to register in the system with either a public sector clinic or with their doctor, and that is where they primarily will get their care. So this model that we have structured for South Africa, and there are several countries in the world who've gone this route, is what we call a single payer system with a purchaser-provider split. That's not to say there's only one payer, because there are exceptions that will allow medical schemes still in the system, as you get in the UK, for instance, but it is technically a single payer purchaser-provider split. So the fund is the purchaser, purchasing the health services, but the fund will also procure medicines and health goods and health-related products for us as the nation. Now, procurement is not buying them. It is setting the prices and the standards and deciding what it is that the fund will pay for. And there will be an Office of Health Products Procurement in the fund. So the important thing is that the fund will achieve greater equity. Again, over time, it's not like you switch it on and tomorrow everybody has equitable access to everything. It will achieve greater equity by strategic purchasing. So at the moment in the public sector, the government departments get fixed budgets, and those budgets tend to slow down productivity. There are no incentives to see more patients, the facilities become overcrowded, and the whole system winds down. The opposite happens in the private sector, where we have a fee-for-service system, and like elsewhere in the world where there are fee-for-service systems, the incentive is for the provider to do more and to charge more, and there's always over-provision, and costs always escalate in fee-for-service systems. So what the NHIs around the world try to do is to match population need to benefits and pay for what is really needed by the public. And so that's what drives equity, and there are various ways in which the fund as the purchaser does that. So the next big question is, who's going to pay for this? Where's the money coming from? And all the people pro and against the NHI fund will publish massive figures in the media, but they won't tell you that what they've actually costed is the money that's already in the system. So the answer is that any health system, whether it's an NHI or any other system, only costs as much as you decide to spend. And we spend 8.5% of GDP, as I've said, and that's enough. In fact, for countries of our size and our GDP, 6.5% should be enough. We shouldn't even need to spend 8.5% of our GDP. But let's assume we are able to spend that 8.5%. What's the problem? Well, we waste. We have fraud and corruption and theft, both in the public and the private sector. We have massive administrative overhead, some of which I've spoken about already. We have supplier-induced demand, which creates very significant over-servicing. We have extremely poor coordination and incompatible systems. Even in the public sector, within one province, the systems don't speak to one another, never mind between provinces and between the public and the private sector. We have very little coherence in any form of coding system, so we can't compare what is happening in one part of the system to the next. So we have to get rid of that poor coordination, and we need to get compatible systems. And then we fail to capitalize on scale. The public sector does, to a certain extent, capitalize on scale, but it's nowhere near what we could be doing with 8.5% of our GDP, or the portion of the 8.5% of GDP that is used on services and so on. There are other ways to reduce costs. Our people costs are ridiculously expensive because we have our specialists doing generalist work and our generalists doing nursing work and our nurses doing community health worker work. And I've, as you heard, worked all over Africa. It's crazy the way that we've set up our system. And it's not satisfying to work in a job where you are doing things that are way below what you are qualified for anyway. So we can use our people, and I'm talking now the clinical people in the system, far more efficiently. I've spoken about the wasteful procurement. Our medical legal liability is ridiculous. We are one of few countries left in the world that have this antiquated medical legal liability system, and we need to move to a far more efficient system. And fortunately, there is a process on the go to do that. And if we could move to something closer to the Scandinavian or New Zealand system, we wouldn't waste money on 20%, 25% on legal fees when and elevated costs for paying for our liability. Okay, and I've spoken about the other things there, and I'm going to run out of time, so I'll just briefly speak about health technology assessment and proper regulation of our health products. Those are things that we have in fledgling arrangements at the moment, and we really need to improve on them. But the big trick is to redirect the cash flows that are in the system. The public sector is already tax funded, and there's already 256 billion rand in the public sector. But the problem is the money does not go to a health budget. The money goes to provinces through what are called provincial equitable shares, and they aren't equitable at all. And then out of the equitable share, each of the provinces slices out a portion and puts it into the pot for health, and those get added up and they get called the health budget. That is not an equitable way to deliver health services or to plan a health service. So a single purchaser can monitor equity, whereas with the many current providers, purchasers of services, you can't do that. But that shifting of provincial equitable share allocations back to national and into the fund requires quite significant political power shifts and function shifts. And it has to be done slowly in budget cycles, otherwise the whole system can collapse. The private sector, of course, is voluntary at the moment. And those of us who are able to afford will purchase some form of medical care. And it's virtually impossible to choose the appropriate package because you don't know how sick you're going to be or what you're going to have next year. And if you only just got this much money, you have to go to a broker or somebody to try and interpret it for you, or you don't have it voluntary at all. Your employer tells you how it's going to be. To shift those funds into the NHI fund is what the private pundits get all excited about, because it needs to be shifted through taxes. And they may be new, but they may be the same taxes that are just more or differently structured. And of course, they need to be pooled to the greatest need. That is probably not the biggest problem. The biggest problem is probably the shifting of the provincial equitable shares. Okay, let's talk briefly about registration of patients. So the way that the system is being set up is that there's a health patient registration system that generates a unique number called the HPRN for every patient. People ask us, why didn't we just use the ID number? Well, because the ID numbers there are 600,000 duplicate ID numbers in Home Affairs at the moment, and we can't afford to have the wrong patient getting the wrong treatment, or with ID theft, giving a medicine to somebody who's got penicillin allergy because we thought it was the right ID number. So we are embarking on a different system, and we're working with Home Affairs to help them fix their system, but this is the way in which it's been designed. Will GPs and facilities be able to retain their patients? Yes, of course. The choice of a practitioner at primary healthcare level is the patient's choice. The only difference is they can't choose to go to their pediatrician with bypassing the GP. That's the difference. They have to go to the GP, and the GP will be the one who will advise them or refer them to either a pediatrician or obstetrician or whatever other specialist, except in a case of emergencies. Will there be a certain minimum number of patients needed? No. But the way in which the system is structured around what are called risk-adjusted capitation system. And we're going to talk about that in the next seminar, so I'll skip it now. So what happens if patients come who are not registered? Well, then you register them. So you see them, you register them. If they've got a name and an ID number that matches the system because they've been somewhere else, it's easy. If they haven't been, they have to fill in a form, which is on an electronic template, and they'll be registered there. That template will tell you quickly whether they are legitimate or not legitimate. But even if they are a foreigner who's illegally in the country, they will still be, you can still register them, provide a service, and you will still be paid as the practitioner, but that person's record will be flagged, and we will be able to see them when they arrive elsewhere in the system. And they are, as the bill is structured at the moment, not entitled to all the care that a resident or a citizen is entitled to. What information do you need on patients when they register? Well, at this stage, you just need to know where they live, because we are trying to get a geographical footprint of where patients are. And then there are information around their bio. Who is this person? And people ask me questions. We don't want to give our gender. Well, in healthcare, we want to know your gender. But if you want to choose an alternative gender to male or female, that's fine. Because then when we start providing clinical care to people and we see that we're doing a hysterectomy on a male patient, we pick up that we are actually dealing with someone who's transgender, and it's more complicated. And we know that we have to look after this patient in a special way. So that's the kind of information. But we are going to collect and identify and verify people using fingerprints. You might ask, why not facial recognition or retina? But it's because of the cost involved. And so for now, we're using fingerprints. How will our patients be divided between public and private facilities? No division. Today, I might decide to go to the GP, and then down the road, which is the person I would normally go to. But then I find myself at work tomorrow and I'm not feeling well, and I either go to the occupational health clinic or the public sector clinic down the road. It doesn't matter. I go where I go for healthcare, and my records will be portable, and we'll talk about how we get portability of health services. But you remain registered with that practice, because that is where we're going to count what happens to you and the clinical case mix, and get an idea of whether we're achieving equity or not. Okay, so I think that's for today. Next seminar, we're going to talk about the accreditation of practitioners and providers, and we're going to talk about remuneration of practices. So I'm not going to go into those today. So let me end there and we'll take some questions. Oh, let me just say, NHI is not a panacea. We are not naive enough to believe it will solve all the problems, and certainly not immediately. It is a different financing mechanism. It will require a different service delivery system, but the point of departure that we are aiming for is equity and social solidarity. We want to cover more people with a greater range of services, with a lower cost at the point of care, with the improved quality, and we want, in other words, we're trying to achieve universal health coverage. Thanks.
Great. Thanks. Thanks, Nicholas, for that overview. So now I see there are a few questions in the question and answer, and I would encourage everyone to not be shy. And this is your chance to ask questions, maybe even to suggest things that are particularly relevant to our space, the primary care and district health services space, and to enter into a bit of a dialogue. But I'm going to get the ball rolling. So the first question is from Shelley McGee, And the question is, I am concerned about the purchaser-provider split, given that the Minister of Health presides over both purchasing and provision. How will there be, or will there be, a genuine split between purchaser and provider?
Okay, so Shirley, thanks for the question. So obviously there are concerns that have been raised during the parliamentary hearings around the structure and governance of the NHI fund. At the end of the day, somebody has got to be held accountable, and it's in the performance contract of the president and the minister to achieve the outcomes and to set up the NHI with its services. The fund is supposed to be, and is designed to be, arm's length from the minister with a board. But people have complained that the way in which it is structured is not going to achieve that. Well, I'm not going to comment on that because it's in the parliamentary process, and we are likely to see those comments shortly and be asked to respond to them, and maybe we can tighten some of that. But we are genuinely aiming for a purchaser-provider split. Remember that pretty close to 50% of all provision happens through private providers. And the minister may be the minister that provides over the National Health Act and therefore regulates both the public and the private sectors. But the minister does not run even the private or the public health sector. You ask somebody who works in a province, they'll tell you clearly the minister does not run the services in this province. So I think we do have a chance to get a genuine purchaser-provider split.
So the next couple of questions are from Shabir Musa, and I think they're sort of related. So it says there are clearly duplications with HPRS. Ask any clerk at a clinic.
Yeah.
How will this be solved to prevent ghost patients? I mean, can providers not commit fraud and create ghost patients if they can register? And how will this be validated?
Okay, Shabir, good question. So at the moment, there are duplications in HPRS, and that's related to the challenges that we have with the source of the data for loading the HPRS. And as I've indicated,
what HPRS is?
Health Patient Registration System. I did refer to it in the presentation. You see, not everyone is paying attention. So the HPRS is the system that generates the HPRN, which is your unique patient number. So at the moment, there's no fingerprint ID in the system. So there are 3,600 public health facilities and 35 hospitals that are connected, all in the public sector at the moment. And obviously, we would like to start piloting this into some private practices to see how we can get the HPRS to function and the portability of services to happen between the public and the private sector. So once we start fingerprint validation, it becomes extremely difficult to duplicate a record, but probably not impossible. And the hardware, a lot of the hardware has already been procured and will be rolled out. And so even when you start to register patients and see patients on the HPRS in the private sector, in your rooms, you will be connected to the system and you'll be able to see that this patient is indeed the patient who they say they are. That validation needs to be real time, obviously, and that's a challenge to us because about 20% of public health facilities are not live connected to the internet, and we are busy with a connectivity program at the moment, which we can talk about another time, so that when a patient arrives and you have to validate them as that patient, as that person, and you don't mix up their health records, because as a physician, that's your problem, is mixing up the health records, not whether you're going to be paid or not, then yeah, obviously we want it to be live. Thanks.
Excellent. So, so this question, next question is, will your full-time employed doctors and dentists who work a full day, will they work a full day? I think this is talking about people in the public sector, instead of ducking and diving to their private practices during the working day. So how will NHI impact on that habit, I guess? How will you monitor that these professionals will be at their posts to do their work?
Okay, so this is a great question, and it's a hobby horse of mine because I believe that RWAPS is unethical for health practitioners and it should have been banned long ago. Unfortunately, it's part of the Public Service Act and it has become an entrenched practice across the public sector. But it's supposed to be done in a responsible and ethical way, and I'm afraid it's not. So what are we going to do in the NHI? So in the data systems that are under construction at the moment, and we've made a lot of progress, I don't want to give too many technical terms, so let me try and simplify this. We have a what's called the MFL, a Master Facilities List. And those of you interested in how these work, the WHO website talks about Master Facility Lists quite comprehensively and well. So our Master Facility List in South Africa has every single establishment in the country. In the public sector, we are convinced we have 100%. We know every single physical location and we know what goes on in that facility. And over time, the detailed descriptions of exactly what is happening will be updated on at least a monthly basis. So we will see theaters that are down, wards that are closed, beds that are available, et cetera, et cetera. For the private sector, during COVID, we loaded every family practice that we could get. There are 11,000 on our register at the moment. We loaded all of the private hospitals and day hospitals, and we started to load all the pharmacies, the physios, the OTs, people who have rooms and practices outside. So the one part of the system is called the Master Facility List, and it generates a unique number for each establishment, we call them, and that will be the number for that place forever. So if you add a practitioner or take a practitioner away or change your benefits, you will still have that number and we will still know that there's a place there that's delivering healthcare. Secondly, there's what we call the provider registry. And the provider registry is a database in the NHI, but it is basically drawn directly off the professional association registers. But we know that they include people like who are retired, who live in other countries, and so on. So we are only interested in those who claim to be practicing in South Africa. So if you're a doctor, your MP number, and we will link your MP number, we will register it every single time it is used in any establishment. So if you wander around between establishments and are not supposed to do that, we will watch you. We will know you moved, and we will be able to track the behavior of every single person. Not only that, every time you fill in a code of a diagnosis, of a mobility of a patient, of a medicine that you prescribed, of a whatever is in our coding system, and we can talk another time about coding systems. Every time the physician does that, or the physio does that, or the nurse does that, the system triangulates between the establishment, the provider, and what you are doing. So whether you are prescribing a medicine, or whether you're off the formulary, or whether you are physically recording what you did to the patient. Of course, the actual patient's record is not visible to the NHI. That's private patient information, and that will be portable with practitioners with legitimate, valid MP codes, and there will be physio access, and there'll be dental access, and so forth. Using your appropriate code, you will be able to see portions of the patient's record with portability. So that links us to the user then, with the user number and the patient. So all this triangulation of data is packaged in a way and is secured in a way in our data warehouse that it's extremely difficult to hack. It is also linked to what you're going to get paid. So specifically for hospitals and specialists, it's linked to the DRGs, and the structure of the benefits is yet to be agreed with everybody. But it will also be linked to where a family physician sits in a contracting unit for primary healthcare and how they are part of the multidisciplinary teams within that care environment. So this is what we are busy putting together, triangulating, looking for the flags that you will see at practice level as you see a patient, that the patient is crooking the system, or the doctor's crooking the system, or somebody else is trying to hack into the system. So if you, in 2 weeks' time on a Sunday night, the SIU has a webinar. I can send you the details of that. You can always join in and you'll hear the discussion on what we're doing about fraud, corruption, and risk identification in the system. Thanks.
Thanks, Nicholas. So I'm going to jump in with a question, maybe a little bit in response to that. So in your presentation, you had that, I think you had a statement that that there would be, the NHI would contract directly with service providers. And now you talked in this last answer about the sort of the master list of establishments, of health establishments. And I know we've spoken about this before, but just to sort of unpack this issue of who will NHI actually contract with? Is it going to be the service provider, the person, or is it going to be an establishment? So the GP practice, for example, would have, or a community health center in the public sector would be contracted with. How do we resolve this, and what are the issues around what people refer to as the juristic entity, I think, in legally?
Yeah. Okay, so yeah, thanks, Bob. As you say, it's a complicated environment. I would have preferred it to be simpler, but the way that the bill has structured it, it says that in the primary healthcare environments, the fund will contract directly with a contracting unit for primary healthcare. And it describes the amendment in the National Health Act that will be brought about by the fund to structure these contracting units for primary healthcare. So in the primary healthcare space, there will be a defined set of benefits, and we are working very hard now with CMS to harmonize what happens in the private sector and the public sector, so that we come out of this exercise with one common understanding about what happens in the primary healthcare space. Clinically, I'm talking about, and when a referral happens and doesn't happen. So what the bill says is that the fund will transfer, is the word that it uses, funds directly to a contracting unit for primary healthcare. And that the contracting unit for primary healthcare will be responsible for contracting the providers in that geographical space. Then in the amendment to the Health Act, it says that a contracting unit for primary healthcare is a sub-district that is in the catchment area of a district hospital, which is intended to be the first line referral facility for X-rays and more sophisticated laboratory tests or admission, maybe for setting a plaster of Paris for those who don't have that capability in rooms, for instance. So the fund will, in the case of primary healthcare, probably have about 260, 270 cups that it will pay through. Exactly what that cup is and how it's going to work is the subject of much discussion at the moment. And during COVID, I've spent a lot of time with various GP buddies and individuals, and even spoken to people in different countries abroad to try and understand how we get the family physician and the GP into multidisciplinary teams. It doesn't have to be co-located, but they do need to be working together to add value and to add clinical value and clinical outcome value in a contracting unit for primary healthcare. There's nothing in the bill that says that we can't do value adds, but there's nothing that says we have to do value adds. Obviously, I'm looking at a value add where we would look for a key number of outcomes, and we would find those practices who get outcomes rather than outputs would be the ones who would be reimbursed better. But that we're a long way from there, and we hope to start putting some proof of concepts in place next year. For the rest, outside of the primary healthcare space, the 800 public and private hospitals plus specialized services and so on, the fund will contract with them directly as establishments and not with the physicians or physios or other professionals inside them directly.
Okay, thank you. I'm going to go back to the list. There's now 16 questions on the list. I'm not sure if we'll get through all of them. The next one is quite specifically, I'm not quite sure the context here, but it says in early 2019, the National Department of Health contracted the universities consortium with much fanfare at UFS, a partnership of 6 universities that promised to invite others who are not part of the consortium. Nothing has been heard of it since. What's going on?
So thank you, Edith. The short answer is the contract was terminated. There were legal problems with the contract, according to what I've been informed. But I'm aware of it. I wasn't there at the time, but I have asked what's happened with it because I thought we might be able to use it for some of our these pilots, and I'm told it is not continuing, and there's no money left to continue with that contract. Thank you.
Thanks. So now Shabir again asks what I think is a very simple but actually quite interesting question. How will patient choice actually work? How will it operate? And I'm also interested in this question in the sense that, obviously we also want continuity of care with patients. We don't want to encourage patients to just go anywhere they want at any time. Presumably we would like people to have a home, as it were, a practice home that they attend and they're known. We know that that relates to better care. And yet my understanding is that I originally thought that patients were going to register with a particular primary care practice, but from our previous conversation, I now understand that they're going to register with NHI, can actually go anywhere they want, and that a practice will not really know how many patients it has, which of course then begs the question, how will you pay a capitation fee if you don't know how many patients you have? So I'm elaborated on Shabir's question, but maybe you can address that. Yeah.
Okay, so the intention is that the patient registers with the NHI, but they register at a point which they declare as their primary point of choice for healthcare. But we have a very mobile population in the country. Even I am a migrant laborer, so I have a healthcare practitioner here where I live, where I am at the moment. But when I'm at work, and fortunately now we do more webinars, I don't travel as much as I used to. But when I'm in Pretoria, there's another practitioner that I would go to for care there. And the dentists are even more difficult because you need a dentist now if you broke a tooth. So where do you go? So the intention is to offer those choices, and that the patient will register that this is where I choose to get my first point of care. As I've said, if you use a place near your home, but you are working in Soshanguve, you live in Soshanguve and you're working in Roseland, you might go to an occupational health clinic a lot more than you go to the place you actually designated to attend. So that does present a challenge of capitation, of who's being paid for what. As far as choice is concerned, the patient exercises that first choice to register on their primary registration with the NHI, that this is my primary point of care. Now you see the patient and you say, you're going to need an admission, for argument's sake. The patient says, okay, let's say it's something pretty straightforward that can happen in a district hospital. But you're going to need an admission for whatever, investigations, maybe minor surgery. Now the primary point of referral will be to that district hospital. But there may not be beds at that time. There may not be the people who are able to provide that care, because not every hospital has everything available to them right then. So there are a primary referral and there will be other referrals. So you may find if you're stuck out at Malamulele, there's no choice. There's one referral hospital for that. But you may find that there are two. So Malamulele is not far from Giyani. So there may be that there's the Nkitsani hospital, but there's also a private hospital in Giyani. So there may be more than one choice. And on the system, the practitioner should be able to see where there are beds open. And there's a booking system in the referral, well, in the design so far, it's not live at the moment, but there's a booking system where you would be able to ensure that there is a bed available. I'm using that as an example, but not all referrals work like that. Some of them are just talking on the phone, and there are other kinds of referrals. So there is some element of choice, but what we are trying to exclude is the bulk of patients must not choose to bypass the primary healthcare system. That's the main point.
Okay, thanks. So I'm going to try and get through as many of the remaining questions as I can. There's a couple here that I think was a theme also in the survey around things like corruption and fraudulent claims. I'm going to take those two together. So the one is the current high prevalence of corruption in the community How is that going to be addressed in NHI? And the other is, how will fraudulent claims and reimbursement of fraudulent services be monitored? So in other words, how will you know when you're being taken for a ride?
Yeah. Okay, so clearly this is a matter of grave interest to us. If we think that probably within the next 4 to 5 years, we'll have between 2.5 and 3 billion rands worth of the NHI money will be going through the account in a week, every week. So let's say 3 billion a week going through the funds. You don't want to have holdups all the time that you're querying accounts and so forth. So what one tries to do is design the systems that as much of it is automated as possible, that is as much triangulation of data as is possible, and that you block transactions as far as possible where they are clearly aberrant. But sometimes those aberrant transactions, when they are flagged, are legitimate. And so you want a system where the fund is able to identify very quickly so that that payment doesn't get held up. The rest of the payment can go ahead, but that payment doesn't get held up. At the same time, the opposite can happen. We don't want to have paid and then establish that there's been fraud in the system. So there's fraud and there's corruption, and then we talk about risk. So risk is where you try to understand the structure of your system and where might who try to crook the system. Patients crook systems all the time. Ask the medical scheme. Patients, practitioners crook the system all the time. Medical schemes will tell you, we will even tell you from within the public service. They steal products, they overprescribe, they take them home, they do all kinds of strange things happen. In the provider environment, that's a provider's problem. In the purchasing environment, that's a NHI's problem. And we will need to, as I said, we are working very hard to identify those risks and to stop them. But then outside people also try and defraud the system. They load benefits, add benefits onto the bottom of patient records and so forth. When you do the audits on those patient records, and you start seeing a patient getting an appendectomy for the second time and so on, as the data starts to build up and it tells you this ID number's already had this, and it's not something that can be done twice, like removing tonsils or appendectomy, or it starts to show you that the pattern of the behavior of the consultation is not monthly, it's weekly when you expect it to be monthly. It'll flag it and it'll be investigated to see whether this is fraud or whether this patient genuinely has a complication. You can't exclude everything. So what you then do is you put as much as possible of the transaction summaries into the public space so that people can see and can complain. Hey, this guy's claiming for this or claiming for that and so on. So the systems are being built from experience. Private sector tells us their experiences in the public sector and other countries, and the WHO is extremely helpful telling us stuff. But over time, you get smarter and smarter, and the systems are getting more and more efficient. And with machine learning, it's unbelievably quick how we pick up aberrant behavior.
So while we're on the topic of machine learning, and I mean, like a lot of what you've said, I mean, on numerous issues in the, it seems to require a really amazing IT system with, like a national database with everything interconnected, patient registration, patient records. I mean, I see there was somebody that asked now.
Robin died.
This. I mean, you talk, what you talk of is a highly sophisticated, electronic health record. I mean, like, it sounds fantastic, but I mean, how realistic, how feasible is it that we can get this up and running? We seem to have struggled for the last 20 years. And the question here, is there a super EHR or interoperability of public-private systems planned, especially as different provinces are already rolling out electronic health records? So just, I think there's a question here about, is it pie in the sky or is it really possible?
No, it's not pie in the sky. It's very possible, and we've seen other countries do it, so we know that it can be done. And we've had some visits to other countries to see what they do. So these things are genuinely feasible, even for us who don't like to work with one another and like to all do our own thing. And the starting point is interoperability. So first of all, you don't want one system where everybody uses exactly the same software, because then if something does break, everything's broken. You do want interoperability of systems, and that interoperability has got to be designed in a way that you don't waste space and you don't waste the digital highways that are expensive to maintain in data transfers if you don't need to be transferring the data. But you do need certain data to be accessible all the time. The problem has been we've never regulated what you have to have. So you are going to start to see a lot of regulation taking place around data, and this is provided in Section 74 of the National Health Act, but it's also provided for in a whole chapter of the NHI bill, where the NHI is empowered to do certain things. So the health system, the national department, need access to data for planning and for policy formulation and so forth. The NHI needs data for administering the system and for paying people and for monitoring that we are able to distribute the resources and the way in which we provide healthcare and so forth. So the patient record is one small element, a very important but a very small element of the National Health Information System. You don't need that patient record to be sitting in a national data frame or data space, but you do need interoperability so that from one clinic to the next, or the clinic to the GP, or the clinic to the hospital, it is possible to access that record. So its structure of the software and the way in which the hardware interacts with that software has got to be standardized. So we've had national standards since 2014. They have just been redone, and the public and the private sector have been involved. There were over 120 people at the workshop in February when they were finalized. They got held up by COVID, but they have been through the legal advisors and are with the DG and ready for authorization to be gazetted. Every province, every private provider, anybody who wishes to be accredited needs to read Section 39 of the NHI bill, and they will quickly note that if you buy or implement a system that is not interoperable according to those standards, and Robin Dyer had a question on the chat a moment ago, if they are not able to have that interoperability, they are going to have to change their system. So to help people to understand whether the systems are interoperable, whether that's a vendor who's selling you the systems, or whether that is a provider themselves or somebody who built their own system, we are offering, or we'll shortly put it in the public space, a laboratory where you can go and have your system checked, and the report will tell you what needs to be done to make your system interoperable. Clearly, you do need a data center to manage this, and the data center has already been built, it's already been implemented, and we've been using it for COVID. So this is not pie in the sky. This is definitely doable.
Thanks. So we're almost out of time, and I've got two, I think, final questions, which are completely unrelated, but I'll give you both of them. So the one question from Klaus is, any training or certification requirements anticipated for participating GPs? And I think this, for me, also relates, of course, it's organized by the Academy of Family Physicians. So I think related to Klaus's question is, how are you going to sort of handle, family physicians within the primary care space? And then the second question, very different, which I'll read out, says currently the PBM framework and legislation allows medical schemes to apply managed healthcare principles, which results in limitations on benefits and so on, which also results in out-of-pocket payments from members who are obviously now not covered. So will these principles also be applied for services rendered under NHI? If so, who will be responsible to administer the risk management? Okay, so one So two very different questions, but maybe you, in the last 2-3 minutes, you can
Okay.
quickly
Thanks,
cover them.
Bob. Okay, so very quickly, Klaus's question on certification and accreditation. There are different things in our legislation, and that may cause a bit of confusion. In order to engage with the National Health Insurance and be paid by National Health Insurance, the first step is that both a practitioner and an establishment must ensure they are accredited. The first step for a practitioner to be accredited is to be registered with your professional council and to remain up to date. And each professional council has their own regulations and requirements around continuing professional development, etc., etc. The second step is certification by the Office of Health Standards Compliance. Those standards at the moment are only called establishment standards. And for now, for this current phase that we are in, we are using those standards, not all of which are applicable to a general practitioner's rooms, maybe more applicable to a health center or certainly to a hospital. And there will be ongoing discussions, and we are planning with the Office of Health Standards Compliance how to engage with practitioners to get to a second phase where the standards are tailored to practitioners, let's call them rooms. So that's the second step. The third step is accreditation. And accreditation says you have to be registered, you have to be certified. There are other bodies and other legislation that cover those. Now, you must be compatible with our systems. You must be willing to provide this certain information. You have to comply with the formulary. You have to comply with the clinical guidelines that are issued. You have to comply with this and this and this. And the way in which those are going to be implemented have not been designed, so they're not in the public space. And until we get the legislation approved, that just remains Section 39 of the bill. Okay, the last thing about the PMBs and the legislation and all of that whole private environment. Obviously, we're moving towards a point where you shouldn't need a medical aid. None of us should need a medical aid at all, because the bulk of the benefits that we are likely to need are going to be paid for by the NHI, and there will be providers in the system who are accredited to deliver those services. But getting there is the challenge. So we are working closely with the Council for Medical Schemes at the moment and segmenting the work. We're saying, what did the HMI say? What are we saying about PMBs? What are we saying about these insurance products that are outside of the medical schemes and are frankly, virtually unregulated, because the Financial Conduct Services Conduct Authority and the Prudential Authority are trying to manage them with Treasury. So how do we harmonize all of this and squeeze it into a situation where it's legitimate, manageable, fair, and that the risk is reduced? So I don't have the answers to all of the questions, but I can tell you that there are forums. We have a big forum with Treasury, FSCA, Prudential Authority, and CMS, where we discuss those issues, and we are working very hard on the PMB framework, discussing with medical schemes and trying to harmonize with the public sector. So it's not going to happen overnight, and it's not all going to be solved at the same time. These things, as I've said, if you over adjust them, you can actually break the system. So we need to work systematically and gently to get rid of the bad practices and reinforce the good ones. Thanks.
Okay, so I think our time is up for tonight. I just want to thank Nicholas. He's got lots of energy to answer all these multiple questions. Some of the questions that you asked we haven't addressed, and I will keep them, and hopefully we can address them, many of them, next time. So the next webinars of conversation with Nicholas Crisp will be on the 19th, also at 4 o'clock. It's next week. In the meantime, I hope it's been interesting and valuable, and we hope to see you for the next half of this conversation next week. Thank you very much, and goodbye.
Thank you, Bob, and thank you all. Bye.